we start, right? So, welcome everyone to the parallel session 3.3 on capacity strengthening. I'm Deborah Bader. I'm a project officer at EDCTP 2, and I'm here with my colleague Michelle Ndero, who is also a project officer at EDCTP 2. And during this session, we have 5 presentations, and after each presentation, we want to take 1 or 2 questions, but we will also have time at the end to have more questions. And with this, I give the word to my colleague.
Thank you, Deborah. So I'm honored to be actually chairing this session because this is an area that's very close to my heart, and that's capacity strengthening. And I'd like to take this opportunity to call up the first presenter, who's George Kay, and he will be speaking on building capacity for HIV cure research in Ghana, the HCRIS experience. He's from the University of Ghana. Welcome.
Thank you, Michelle. Can I have my slides, please? Yeah, first one. Okay, thank you all for coming to this session. So today I will be speaking about what we've been doing with an EDCTP senior fellowship grant that we got in 2019, what we've been doing with it so far. So this is the audience that does not need this slide rehashed, but just for good measure, HIV still remains a global health threat. And if you look down, especially for children, the number of new infections and the number of deaths is not acceptable. Now, we all know that antiretroviral therapy, or ART, has made significant inroads into HIV control to the extent that now a lot of patients who are on ART are able to control the virus and able to live much, much longer. In some places, they even live pretty much normal lifespan. However, ART does not eliminate the virus. And in the clinic, I'm an infectious disease physician. You see a patient, they are on ART, they are taking their drugs, the virus is suppressed. If for some reason they stop taking the drugs, for some of them as early as 2 weeks, you will see significant viral rebound. So the reason is that the virus has what we call the viral reservoir in CD4 positive T cells. And in these T cells, the virus is latent. So whenever you stop the medication, the virus just comes back. So HIV cure, all the efforts are trying to find out how do you eliminate the virus from this latent reservoir. Now, one would say that, now we all know that, if you have people taking their medications and the virus is suppressed, then they cannot transmit the virus. So if we're able to get everybody on ART, that is, theoretically, if you get everybody on ART, everybody to suppress their virus completely, then the pandemic will come to an end. But we know that is not really feasible. So why do we need an HIV cure? So life expectancy still remains reduced. ART is not that easy to take if you are taking it. Even now with dolutegravir, that has been rolled out in Africa. If you go around the posters, you can see that there's a lot of problems with dolutegravir that it's especially being experienced in Africa compared to other places. There's the stigma, and then there is access. Despite all the successes, about 30% or more of people who have HIV still don't have access to ART. And of course, most of ART is donor-driven, and if they stop their funding, most treatments in Africa will come to a halt. So there is a good case to get a cure for HIV. So the past 10 years have seen significant advances in cure research. I will not go over everything. This is a review that we wrote recently, looking at all the cure methods that are being researched and looking at the ones that we think may be more feasible to implement in Africa. One of them is what we call the shock and kill approach. The idea behind this approach is that while the patient is on ART and their virus is fully suppressed, you give them another agent that reactivates the latent virus. And then because they are on ART, whatever virus that is produced will not infect other cells. And then the immune system or other agents can kill the reservoir to the extent that now you can stop giving the patient any medications at all. There's another method that we call the block and lock approach, where the idea is to permanently lock the virus into the HIV, into the person's genome, such that if you stop therapy, the virus is not going to come back out. That seems like a crazy idea, but it's not very crazy, because if you look at the human genome, there is about 8% of it is made up of endogenous retroviruses. So those are viruses that you picked up over evolution, and some of these viruses can actually be reconstituted in the laboratory. But they are not causing any problems for us because of epigenetic modifications. There's gene therapy and transplant, and then there is immunological therapies that are all being researched. The problem is that, and now comes to the point of this, what we are doing is that most of this research is being done in Europe and in the US, where they don't have the burden of HIV. In addition, most of the research is being done on only one subtype of HIV, which is the subtype B, which is predominant in Europe and the US. All the other subtypes that we have in Africa are being neglected when it comes to HIV cure research. So you can have a situation where a cure will be found and it will not be applicable to us. And then we'll get to that COVID thing all over again. So we think that HIV cure should be prioritized in Africa as well. And African patients and African scientists should take the lead in doing some of this research. So if you take just a quick look at the literature, that is what seems to be. So our group, led by Dr. Lamte, who is here, and others, we are doing a systematic review to look at all the literature on HIV cure since 2010. This is just partial results of 575 publications on HIV cure. We have about 1,500 by the time we finish. Now, if you look at the one on the right side, the total number of studies out of the 575, the total number of studies in Africa is about 50. That is, and then the number of publications coming from Africa on this is even less than 50. So still in this 2023, there are still samples being taken from Africa without the Africans being on the publications. And you can see the same when you look at the yearly publications there. So we think that this situation needs to change. Here are arguments for why HIV cure should be done, research should be done in Africa. There are questions about the HIV reservoir that can only be answered with African patients. For instance, there are co-infections with tuberculosis, co-infections with hepatitis. There's HIV too that occurs only in Africa. There are many, many variants, especially for us in West Africa. We have so many different interesting HIV variants that all of these may affect what we call the HIV reservoir and the immune response to it. And therefore, it is critical that we get involved in this research. There may also be acceptability issues with African patients. What kind of risk are they willing to take for HIV cure research? Because some of the things that we do in HIV cure research, what you call analytical treatment interruption, where like you interrupt the treatment with the patient and see whether the intervention is working or not. Will African patients, be willing to do this? So now we come to the HCRIS, which stands for HIV Cure Research Infrastructure Studies. So this is an EDCTP funded senior fellowship program. So I had a lab, or have a lab at Washington University, and I'm from Ghana, and I wanted to go back to Ghana. So I was asking how I could go back, what kind of grant can I get? And then I was introduced to EDCTP. Applied for the grant, and then in 2019, luckily, we were selected for it. The University of Ghana and Washington University were very supportive, and Noguchi Memorial Institute for Medical Research, where I work, supported us with generous lab space and a lot of high-end equipment that we are using. So the aims of the project are to characterize a cohort of HIV patients and evaluate their knowledge and attitude towards HIV cure research. This is important because in most of Africa, the viral load testing is sporadic, so you need to have your own cohort that you follow diligently and know who is fully suppressed and who is not suppressed. Because when it comes to HIV cure research, often you need patients that are fully suppressed to be able to follow them and to be able to do their research. Because often we need cells from patients that are fully suppressed that we will manipulate in the laboratory. The other aim was for a PhD student to screen a panel of 150 epigenetic compounds and African herbal extracts for the shock and kill approach. As at now, this is almost completed, and the student is at Washington University doing final laboratory work. And then we also wanted to train scientists in Ghana to be able to do HIV research. So on the aim one, what do patients think and what kind of risk are they willing to take? So when we asked patients, the rest of the slide are self-explanatory, I'll just go to the C. When we asked about treatment interruption, would they be willing to interrupt their treatment for HIV cure research trials? 67% say no, under no circumstances. 17% said maybe. Now, this result is exactly opposite what we saw in the US, where almost exactly 67% says yes, they will be willing to interrupt. So as to why our patients in Ghana are unwilling to interrupt therapy is something that we are trying to understand. But we also done qualitative studies on this, and what they tell us is that, look, we know ART is working for us. We have seen friends that have stopped therapy and they've gone to chase other cures, and then they ended up dead. So, we are not willing to interrupt therapy, even if the doctor is going to follow me closely. Somebody said the boundary will be if they ask me to stop taking my medication, I will need serious counseling on that. So when we looked at 275 of our cohort of 390 that we had complete data for, viral suppression is pretty good among these patients. If you go by the WHO standard of less than 1,000 copies, close to 90% of the patients in our cohort have their virus fully suppressed. If you go by international standards of less than 50 copies, it's about 85%. Now, this less than 1,000 copies WHO standard, some of us think needs to change. Thankfully, in the latest guideline, they are trying to, there is some language, but it's not fully saying that get everybody to less than 50. It just says that if it is less than 1,000 and the physician is concerned, they can do something about it. Now, we think this needs to change because whilst it helps for still not transmit the virus, it can breed resistance. It has been shown over and over again that copies less than 1,000 can breed resistance. In addition, such patients, our group has determined that their reservoir size, that is the size of the HIV hiding in the resting T cells, is 3 times that of people whose virus is less than 50. So in other words, when the cure comes around, those people are going to be more difficult to cure. So what have we done so far over these 4 years? So we have established all the lab techniques for basic HIV cure research. We had students, postdocs, and technicians trained at my laboratory at Washington University. They came back to Ghana. We can now do all the assays that need to be done, basic science assays for cure research. We've trained at least 3 postdocs. We have 5 PhD students. 1 has graduated. The second one is close to graduation. We have training 6 MPhil students. That is a 2-year master's degree with a thesis. 3 have already graduated. And then we have several technicians that are proficient. Currently, our group stands at about 20. The numbers are always increasing, sometimes I can't keep track. But it has been extremely successful. Now, this group cohort that we've built is helping us to get more grants because we know everything about these patients. We know their comorbidities, their non-communicable diseases, co-infections. We know their viral load, CD4 count, TB co-infection, everything about this cohort we have determined. So these are some of the projects that our postdocs are working on. So Dr. Boni is looking at impact of persistent low-level viremia on the HIV reservoir. That is for patients whose viral load is between 50 to 1,000. And she recently got an NIH R21 grant to study this. Dr. Lamte, who is here, is looking at Fc gamma receptor polymorphisms on the HIV reservoir. She also obtained an EDCTP preparatory grant and several other UG internal grants. And Dr. Abuaji is looking at HIV and cancer comorbidities. So just still counting some of the achievements. So we, apart from the EDCTP fellowship, which is listed at the top, which we got in 2019 to help us get started. Since then, we have leveraged this grant to get many others. We have one from the NIH to study impact of latent TB on the HIV reservoir. I already talked about the one on the low-level viremia and the HIV reservoir. We recently got a large grant from Expertise France to study to study cervical cancer with HBV in HIV patients, where we're going to look at cervical cancer screening, but also looking at the reservoir, HIV reservoir in these patients and why some of them develop cancer and others don't. We have R01 from the NIH R21 to look at how to control HIV latency. So you can see that, the amount that we got from the EDCTP, which is about, let's say, $500,000 or €500,000, has really returned very well on the investment, because right now we have close to over $2.5 million in addition to that. So pending grants, we currently wrote an NIH D43 grant to help us to train more people. We hope to train 12 people with a mix of PhD, masters, and postdocs if we get that grant. We've published 18 papers and about 25 abstracts. So this is my last slide. So lessons learned in this capacity building effort. Institutional support is key. So we have very strong support from the directors of Noguchi and our current director. When she realized that our group was becoming too big, she offered to give us a huge space. that now, we can accommodate all of our scientists, our interns, technicians, and everything. So and then Washington University has been very supportive because I can send students, postdocs, back and forth to go and learn things. Another lesson learned is that this is Africa, expect things to go slow and be patient. So I was a little impatient. I'm very quiet naturally, but very impatient sometimes. And I was like, these people are very smart. Why are things going so slow? But I realized that, things do go slow, and so you have to be patient. Good mentorship yields good results. So all of our mentees, I'm proud to say, have received one grant or the other, which is very, very good. The challenges is usually the slow pace of basic science research in Africa. I don't think Ghana is an exception. Yesterday we heard the same for Mali. Burdensome procurement processes, delay in procuring reagents, all of these things delay. And sometimes when you're writing your report, you're like, if I was in the US, I would have been able to do all of this, but now here am I saying that I need one more year, right? So those can be frustrating, but I think the effort is still worth it. Our next steps is to expand our cohort to cover all of Ghana and many places in West Africa. So if you are in West Africa, please contact me. I have some contacts already, but if you are here and you don't know me, please come and let's talk. Develop the tools to characterize the reservoir, the unique variants in West Africa. So there are 13 tools to characterize the reservoir, and they've all been made for the subtype B. So there's no tool to measure the reservoir for subtype C or for the subtype that we have in West Africa. So we need to develop the tools to do that, obtain more funding to train more people. And then there are a couple of machines that we need that we don't have, that we still sometimes have to send samples to the US. And we hope to obtain those as soon as possible. And then start doing some of the early cure clinical trials. So with that, I want to thank my team, collaborators, and the hospitals that have been so generous to work with us over the last 4 years. Thank you.
I think we have time for one question. Can you come to the microphone here in the middle?
Thank you. So you said that one of the aim was to screen for compounds, which so you were screening from plants or within the, you say the epigenetic, within the, I mean those which are manufactured within the cells or from plants? Thank you.
Yeah, so we have an epigenetic library, which is a library that already exists of approved compounds that modify the epigenetics. We are using that because HIV integrates into the genome and sometimes integrates into areas in the genome that are not accessible. So we try to, if you like, open up those spaces so that we can bring out the latent virus. The African herbal extracts, we are collaborating with an institute in Ghana called the Center for Plant Medicine that produce a lot of herbs and various herbal extracts. So they give us those herbal extracts and we try them on these models. So we have a model cell system that we have designed that has HIV integrated into these cells and in a latent form, and we can bring out the virus when we have a good, what you call, latency reversing agent. So we have laboratory systems to examine these, and we use the compounds or the extras that we get from this center in Ghana.
Thank you, George. Any more questions? Okay, I have a question for you. So I think we've seen throughout the forum that most of the projects are having challenges with getting reagents and maintenance of equipment. from your experience in the United States, what are some of the systems they have in place that you think can be exported to Africa, but then customized for the African landscape, knowing that our continent has its own unique set of challenges, from the top up, So what systems do you think can be exported and customized for the African landscape?
Yeah, thanks, Michelle. This is a really good question. So in Ghana, and I've heard in other countries as well, for people that I've spoken with, one of the key challenges is the procurement system, where like you want to order something and then they say that, oh, bring 3 invoices, and then the companies that supply the reagents also, for some reason, take their time to bring it. So you order something, after you've gone through the procurement process, then they also take 3 or 4 months to bring it to Ghana. So I think there are 2 things that we could do. One is to have a centralized ordering system that is online, so you can fulfill the procurement requirements without having to run around. So in the US, what we do is that they have all the companies that supply have their catalogs in an online space. So you go there, if you want to order an enzyme, you look at it, company A has it, company B, company C, company D have it. You pick the one that you want. So in a way, you fulfilled all the procurement rules right there because you have, codes from 3 companies. So then you send it to the grants office, and then they get it ordered. The other thing we could do, I think, is that maybe we can have, and maybe EDCTP can help with this, we can have regional reagent banks or something where, the big companies like Sigma and the rest can put things there, and then, we can buy from them. Or big universities like University of Ghana can have their own stores where they pre-finance some of these things, and then when the researchers need it, we just go there, pay for it with our grants, and collect it. In the US, most universities have internal stores. So most of my reagents, I just go and just collect it, and then they charge it to my grant. So it makes it easy because if you think of something interesting, you don't have to wait 3 months. You can just work on it tomorrow, and that does help a lot.
Thank you, George. So it's my pleasure. Oh, yeah. Round of applause. So it's my pleasure to introduce Amel Semsi from the Medical Research Unit in the Gambia, and he will be talking about creating a whole that is more than the sum of its part, an emerging collaboration between its clinical units in UK, West and East Africa.
Thank you, Deborah. Let me start by appreciating Michelle Deru, who was the project officer for my first EDCTP grant 10 years ago. So when she says capacity strengthening is close to her heart, I know she means it. I also want to appreciate the presence of some of my mentors in the room and from my colleague. So we are usually used to capacity building flowing from the north to the south, but today I will give a presentation on a beautiful collaboration where the capacity building flows a little bit in all the direction, north helping south, south building north, and south-south collaboration. So this presentation is made on behalf of the London School of Hygiene and Tropical Medicine in the UK, the Medical Research Council in Uganda, and the Medical Research Council in the Gambia. And I am Amel Semsi. I head the Clinical Trials Unit of the Medical Research Council in the Gambia. So it's been 5 years now that the London School of Hygiene and Tropical Medicine as a family got bigger to include the Medical Research Council, the Gambia. You can see the campus on the top. On your left, a building of the Medical Research Council, Uganda. And on the right, the London School of Hygiene and Tropical Medicine. But before coming together as a family, each of these institutions had its unique strength. So, for instance, you already had some organized capacities to really provide support to clinical trials. So each of these institutions, you may already know, has long history of conducting clinical trials in their respective settings, which have really advanced policy and care. So in the Gambia and in London, you have formally constituted clinical trials units, but in Uganda, you had an equivalent resource. Now, if we want to look at each of their specific strengths, concerning the contextual strength, the CTU stands for Clinical Trials Unit of the London School of Hygiene and Tropical Medicine, is UKCRC accredited, which means that they have a long track and demonstrated that they have been able to conduct high-quality, multi-center clinical trials. This is also true for the other units in Africa, but this accreditation framework exists only for the UK unit. Uganda is established, the MRC Uganda is established in East Africa, and they have built some knowledge and strength on conducting clinical trials in that specific context as it is for the Gambia. So the clinical trials unit in the Gambia has more than 20 years of supporting clinical trials in the sub-region of West Africa. In terms of technical expertise, this is not limiting to say that this is only what they can do, but this is what we want to highlight. The CTU UK really has that strong capacity in statistical and methodological expertise, really can take the research question from a PI, a sponsor, and design the right clinical trial that will support answering of that question. This capacity also exists throughout, but we want to highlight it for the CTU in the UK. MRC Uganda can be seen as a platform that can host a variety of clinical trials also, but also basic sciences. And CTU, the Gambia, is really good at managing clinical trials, coordinating and monitoring those trials, and also even providing this type of training to other institutions that want to build their capacity in trial monitoring. Now, if we interest ourselves on the type of clinical trials where, in which these units have really interacted with, CTU UK is really well known for the cardiovascular trials, really assessing medical devices that are inserted surgically in the heart, for example. They are also very well known for bleeding trials, assessing tranexamic acid in women that just delivered and see how it prevents postpartum hemorrhage. They have also good examples of behavioral and social sciences. We have listened throughout the week the efforts of MRC Uganda in advancing clinical trials in the discovery of better treatment solution for HIV, malaria, and also emerging infectious diseases. This is also true in the Gambia, which has a long history of conducting vaccine treatment trials, which have contributed to bring forward solutions, better solutions for various infectious diseases. A lot of trials conducted in the Gambia, for instance, have resulted in vaccines being WHO pre-qualified. And also recently, we have a vaccine trial that has been conducted, and that was FDA approved. The data was used, and the FDA regulator approved it. I am sure the principal investigator of the trial is in this room, Professor Beard. So you can see these institutions had a unique strength, and you will understand with me that if you have to get married with a partner that has a unique strength, that is a powerful partner, and you yourself, you are powerful, you need really to evaluate what will be your strength, but also what will be the weakness and the threats of your collaboration. Knowing your strength helps you to define your vision and know what you achieve, but knowing your weaknesses will help you to avoid disaster and prevent calamity. So we designed a SWOT to better approach our clinical trial. So it will appear to you as an evidence that these institutions are a little bit complementary with respect to the various settings where they conduct their trials. So this is a really big strength because they can bring various experience from various settings on a table. The units also are, because of their long history, are connected to multiple trial sites and networks that they can pull together in this collaboration. But this may not be a secret for most of you. Retention, staff retention in each of some of these CTU can be a real issue. Maybe because the career path as compared to other academic roles is not as very well established in the CTUs as in other areas. And the size of the CTUs is very limited. If the family of the London School, for example, is involved in 300 clinical trials across 70 countries, if you have the scale of that, that's like the third of the globe. So if you put that in perspective of the size of the clinical trials unit, you can find that it's a bit limited. And as in taking the metaphor of a wedding or a marriage, when you pull people together, there can be always just little fights. I want things to be done my way. So in the beginning, in terms of trial oversight processes, there can always be some disagreement between which way to follow on how we provide oversight to SER. But nevertheless, there are good opportunities. Coming together always gives us the opportunity of mutual strengthening, which is what is happening currently. We have the opportunity to create a shared infrastructure for clinical trials that will benefit beyond the school and also to the wider clinical trials capacity. We can support partners which have a vested interest in conducting clinical trials in the setting where we are really well established. And also there is a big opportunity that there is a high interest, I'm speaking under the control of EDCTP, in having strong clinical trials capacity also in low and middle income countries, but everywhere in the world. Unfortunately, the funding for clinical trials unit is a bit limited. Most funding will go to develop the labs, develop the clinical trial site. But in terms of developing the persons and the units that will provide a good management, good oversight on this trial, it is still, it can be improved. If I take an inherent threat, I will say that external partners may not view us as independent. You may be running your clinical trial with the London School, and I say, look, we want Gambia to provide monitoring to this trial, and you will say, no, Gambia is part of the London School. So there is this little threat that people may not view each unit as really independent, and there is currently a limited visibility of capacity of what the CTUs can do for you. So with the knowledge of our strengths and the weaknesses, we have collectively acknowledged that there have been some areas that we can really work on to really come out with a strong network that can provide a better support to clinical trials run in each of West, East Africa, and also in the UK. So far, we have been working to set up a shared digital infrastructure, which will start by already providing or displaying all the clinical trials in which London School of Hygiene and Tropical Medicine is involved. We are working towards developing a really LMIC-friendly electronic trial master file. I don't know how you do your filings in your various clinical trials, but you will agree with me that most of the times the process is still very paper-based, and some of the commercial solutions are prohibitively expensive. So they are thought to develop something that is really friendly to our context, and also developing clinical trial management platform, so that if you are running 3-4 clinical trials in your institution, your processes to managing it is not relying on human brain, but you have some systems that can accompany that. Also, we are working to align some of the trial governance processes. We are thinking of having some reciprocal monitoring, for example, within the institution, within the unit, to align how we provide oversight to clinical trials. And in terms of visibility, the way we address it is by having a website that will display what we can do for sponsors and PI, but also we are running joint seminar series, and we will be starting early next year in running series on practical issues on resolving clinical trials. That will help to breed the generation of clinical trials manager and people that will provide oversight. So we all agree that collaboration is very key to succeed in clinical trials. All of us are here trying to get some networks so that we have the right partners to succeed in our next clinical trial. For a stronger collaboration, what we approach it through a SWOT to acknowledge our collective weakness, but also leverage our strengths, which now inform us on the direction we want to go. And we are very much convinced that the unique geographical disposition of our CTU will create a strong network trial capacity that is more than the sum of its parts. So I want to acknowledge the team across Uganda, the Gambia, and the UK, and thank EDCTP for organizing the conference. Thank you.
Your SWOT analysis, you mentioned staff retention as a weakness. What is your opinion on changing the situation locally?
The short answer, pay more.
Okay.
Now, maybe the more politically correct answer. The staff retention, usually there are many components. But one of the most difficult things is related to the career path. There are some career paths which are a little bit more straightforward, but when you come in, people who provide trial management and trial oversight, some career paths may be a little bit limited. Now, with the higher interest of conducting clinical trials in some of our regions, there are kind of commercial partners who are also there, and for an academic institution to compete with commercial partners can be very, very difficult. You know, some of these will propose 2, 3, 4 times fold the salary that the academic institution can afford to. So there is really that need also to provide funding that will help institutions to retain their capacity and not to lose them like that. We are still happy that people progress in life, that people can recognize that the staff that you train is a really good quality staff. But that is what it is. Short answer, pay more.
Yeah. Thank you. Are there any questions from the audience? I don't see any hands. Now I see one.
Thank you. Thank you for that great presentation. I see that you have a strong link with UK. What is your opinion about having more relations with clinical trial centers from Africa?
Thank you. That's a very good question, actually, from my mentor in medical school. So I'm sure it's not a trap. But I will speak to it, and maybe Shireen may add. There is a lot of interest in being in a network of African sites. That is not only an interest for MRCG, the Gambia, but it's an interest overall. And actually, what I can say is that MRCG in Gambia and MRC in Uganda, they are already in existing EDCTP funded networks, for example. So the idea of being in a network of clinical trial site is always important. So the interest exists. We have strong links with UK, but we also hope it to open it to other partners, not only in UK, but even across Europe and elsewhere. But what I can say is that the interest of having networks can never be overstated. It is very, very important to have that type of relationship. And coming at the trial level, the relationship can be exchange of samples, exchange of data, exchange of capacity, exchange of human resources to support each other to grow and conduct clinical trials in a more efficient way.
There is one more question here.
I'm Veronique Penlap from the University of Yaoundé 1. I'm very grateful to see you here. This is one of our child that have been supported by CCP, who is doing great at FSC. What I want to ask you is that, what are you doing to help those you have left in Cameroon to be as strong as you in doing such good research, impacting our world, strengthening their capacity in doing good clinical trials? Do you have any strategy for them to connect with MRC, especially for those who have already been trained as monitors and so on, who like to be involved in such project with MRC, connecting MRC to our center of research, laboratories, or university? That's what I want to ask. Thank you.
Thank you. A bit personal question. MRC, the Gambia, actually has a lot of trainings that it organizes that welcome people across Africa. It's true, some of these are competitive. So to have the scholarship to go through the training is on epidemiology. We even have a short course starting late November on clinical trials. So there are quite a lot of activities that happen, but in a competitive way. In the UK, I am not sure, but there are also some short courses that are accessible to everyone, but still is competitive. So now, coming personally, I think I will have hoped to escape this question, but I think at the personal level, I have also done my part in drawing few Cameroonians in the field of clinical trials. Unfortunately, it's a bit still limited. We have seen in the morning one of a great Cameroonian scientist, Dr. Fokamu, was highlighting that there is always an importance to bring research within the context of each country so that you can address those countries, those specific countries' questions. So it is still lagging behind, but I have already helped to draw few colleagues, few medical doctors in the field of clinical trial, but this is a bit personal that I will hope to escape and maybe bring it back to the context of the network of CTUs that we are setting up, which will involve some series on practical issue in clinical trials, and people will be able to join to really strengthen their knowledge on managing, providing oversight in clinical trials.
Thank you, Amel.
Thank you very much.
Thank you, Armel, for that very insightful presentation. I can't believe it's almost been 10 years since we last worked together. It's going to, again, actually have the pleasure of inviting another grantee that I've worked with over the years, and that is Abubakar Soma from the Center Muras, National Institute of Public Health in Burkina Faso. He's going to be speaking on a bilingual training platform in data management and sharing to support open science across the EDCTP networks of excellence. Welcome, Dr. Soma.
Thank you. Good morning, everyone. It is a pleasure for me to present our project. I'm Abubakar Soma, EDCTP Fellow from Saint Mira National Institute of Public Health, Burkina Faso. I'm going to give a thank you to EDCTP Michel. I realize that today is my first time to see Michel in person. Thank you for your support. We work together to this project with my team. So, in background, data management has been repeatedly identified as an area requiring strengthening and training. The lack of data management best practices has substantial impact on data quality and consequently study validity. As per EDCTP policy on clinical trial registration, publication, and data sharing, the implementation of robust data management processes is essential to ensure data are of sufficient quality to be shared and reused for future research. This is very important both in terms of compliance with community norms in the global clinical research community. The EDCTP regional network of excellence have been increasing capacity for knowledge and training in data management and sharing as part of EDCTP2. The aim of this project is to enhance and leverage existing EDCTP knowledge used to support secondary data analysis that could be utilized across all 4 EDCTP network of excellence: CANTAM, AACCR, TISA, and WANITAM. The objective of this project, the first one, is to create online modules covering an essential curriculum in data management and sharing, available as one comprehensive courses at a single location and URL in both in English and in French. To introduce the training package to EDCTP network by dissemination, and to develop in-person training resources from the online training courses. The method for delivering this training initiative consists of several components. The first one is online module covering an essential curriculum in data management and sharing. We create also the data management and sharing technical working group from across EDCTP network of excellence to support the development of training modules, and also to add and to the content to ensure that this content meets the training needs. Also, resources for local face-to-face training are developed from the online training courses with tools, case studies, and resources made available alongside the online training package for download and use. What is the sources for current curriculum? We have an EDCTP network of excellent data sharing technical working group. In this working group, we work together. We have also Medal Oxford Tropical Medicine Research Unit, EFOC Central Oxford Department of Population Health, Infectious Disease Data Observatory, IDO, and Chatham House Global Health Program. In this project, we have developed 7 modules. These modules are located in the Global Health Network Training Center. The first module is the principle for data sharing. This content forms an essential introduction to the reason for sharing data, including the motivation and politics involved. It covers key points to consider in preparing the ground for data sharing activities applicable in any data sharing scenario. We have building trust, articulating the value of data sharing, planning for data sharing, archiving quality data, understanding the legal context, creating data sharing agreement, and monitoring and evaluation. Here, this module forms the data life cycle, which include design, collection, curation, storage, and archiving of research data. The contents of and importance of a data management plan and data sharing plan in research. This third is the ethics of sharing individual level health research data. The aim is to respect and protect data subject, to share data in an equitable ways, and to consider for ethical review of data sharing. Fourth, the data governance policy and data access committee. The aim is to equip learners with the foundation knowledge of data management and sharing policy, and it's important using relevant example, and learners to understand the attributes of good data management and sharing policy. Data quality form the data quality attributes, data validation, data quality plan. Costing data management and sharing. In this aim, we have to identify key elements to consider when costing data management for a clinical research study, and to understand costs associated with each step of the data life cycle. The last one is data repositories. How we have to know how to store data and how to transfer the data to someone else. And also, we can see the ideal system emerging slowly. We need to focus on long-term data preservation. Also, data preservation involves safeguarding digital data against corruption, loss, or damage. In terms of results, we can notice that the content of delivery of this training adapted specifically for the need of the EDCTP network of excellence for local training. It introduces and develops knowledge on data management and sharing to support secondary analysis, that responds directly to the clinical research context of sub-Saharan Africa, and leveraging and establish web-based training platform with the Global Health Network. This initiative draws on experience from across EDCTP network of excellence and partners to deliver a comprehensive curriculum in both in English and French. In conclusion, we can notify that the EDCTP network of excellence continue to strengthen their capacity and look toward more advanced data management and sharing solutions that fit their context. This training platform has been designed to provide sustainable knowledge and training foundation for supporting this growth in expertise ties, aligned with the EDCTP network of excellence aim of research collaboration to further raise the quality of clinical research and practice across sub-Saharan Africa. I cannot finish without acknowledge EDCTP, which is the founder of this project. We're gonna give thanks to EDO, Infectious Diseases Data Observatory, and also the Global Health Network, and the NFL Department of Medicine, based in University of Oxford. And also, I'm gonna thank Saint Mirage and INSP, Institut National de Santé Publique, based in Burkina Faso. Thank you.
Thank you very much, Abubakar. Are there any questions from the floor? Yes.
Thank you for this brilliant presentation. I have two questions. The first one is what's the scope of the data you are gathering through the platform? And the second one is how are some of the conditions to access the data for secondary analysis? Thank you.
Okay, this is a great question. So, according to the conditions, so I'm gonna let you.
Là, c'est le canal 2, le canal anglais. 1, 2, 3, 1, 2, 3, le canal 2. Voilà.
Still working on this project, and that the condition to, we have a model about this, the condition to access this data, so by creating the data committee. So if the project finish, maybe all information of there can be available. So your first question, if you can come again, because I have to understand.
The second one, the second one, if I have understood well, it's about having a data storage. Mm-hmm. I was asking how are some of the conditions to access those data you will be gathering in your platform.
Yes.
Are there some databases that we can access upon request? And what are the conditions to access them?
Yeah, I think as I presented before, the important thing of this project is to make data access for scientists. And then to make data access for scientists, you need to sign maybe agreement before getting access to exploit this data for your research. So, but I say that all things are not ready. And then before the end of this project, we can help for that. Thank you.
Are there any more questions? So I have one question. So the regional networks of excellence cover Anglophone, Francophone, and Lusophone speaking countries. And I noticed that the content is provided in English and French. Are there plans to provide the content in Portuguese so that it's available to the Lusophone-speaking countries that are part of the network.
Okay, this is a good question, but if you take this project, it was just to develop content in English and in French. But if EDCTP move a fund, maybe, yes, we can extend, so the content to another language, so maybe I think. But right now, it is in English and French. But I don't know if the fourth network of excellence there are Portuguese country, I don't know. Yes.
So we have the Southern African network,
so
TESA.
maybe.
So the subset of people clapping there, you need to network and tap into that pool of resources.
Yeah, we are working into EDCTP, and then if there are funds, yeah, we can go ahead.
But sometimes you have to think outside the box, right? Can't always be about the funds. You have to look at other ways of getting resources other than funds. As I said, there's a pool of networks there.
Okay.
Individuals who can assist with the projects.
Okay.
There's knowledge, there's talent.
Yes.
Tap into that.
Okay.
All right?
No problem.
Unless I'm wrong. All right. Thank you very much.
Thank you.
So it's my great pleasure to introduce Mavansa Kiti Lubeya from Zambia, and she will talk about breaking barriers, bridging knowledge, inclusion of women in clinical research by addressing gender and diversity regional gaps in clinical research capacity in Africa. Very much looking forward to your talk.
Good morning to you all. At least I can hear a response. Thank you. As introduced, I'm Mavansa Kiti Lubeya. I'm a gynecologist by training. I'm from the University Teaching Hospital and University of Zambia, the site, which is one of the sites for the TESA consortium. I'm sure by now we know that TESA is a household name. That's the Trials of Excellence in Southern Africa. So I'm presenting on behalf of this team, as well as the subgroup that coordinates the female PhDs program. So my presentation is titled, Breaking Barriers, Bridging Knowledge, Inclusion of Women in Clinical Research by Addressing Gender and Diversity Regional Gaps in Clinical Research Capacity in Africa. So I'll share with you the practical aspect of how we are breaking these barriers and bridging knowledge as TESA consortium. So just to briefly give a background, so we've seen that there are so many advancements in medical research worldwide, but then there are still gender and geographical inequalities, especially in clinical research, and women bear the brunt of this. So in Africa specifically, there's a gap which is quite significant in clinical research capacity. And women, to emphasize, are really underrepresented. You agree with me that there are a lot of factors that exacerbate this imbalance. You know, some of them are just historical issues, job difficulties, and cultural expectations. I know here we are scientists and we have different beliefs, but when you go out there, a woman's place is in the kitchen, especially in the African context. And by that thought of just that cultural context where you should act as an anchor in the kitchen, it also brings down your aspirations to achieve more. So these really bring us women down in terms of what we can achieve. So there is really prevention of progress, of inclusive and diverse medical knowledge. So to close the knowledge gap and promote inclusivity, Capacity building efforts enable women in Africa to assume leadership roles in clinical research. Some of the women have been showcased here, and we've seen them. The Trials of Excellence in Africa, TESA, is implementing a PhD training program for females only, funded by EDCTP and UK DHSC. So the overarching goal is to nurture a generation of skilled and knowledgeable women researchers and leaders who will drive advancements in clinical research. Just to refresh you, the countries that are participating in the TESA consortium include 11 institutions from 8 African countries, listed as you can see on my screen, as well as 3 European partners, that's France, the Netherlands, and Spain. So what is Tangendi? This is the acronym which stands for TESA Addressing Gender Diversity, Regional Gaps in Clinical Research Capacity. So we have a grant which runs from August 2021 to July 2025. And this grant supports tuition fees, stipend, and other expenses that our PhD students need. So this is a complementary program to the TESA overall goal, which is reducing these gender diversity gaps within the region. So just to shed some light on how we are doing as TESA with the Tangendi program coming on board, at the moment we have up to 57% researchers represented by women, and for non-research staff we are at 43%, which is a big leap for us. So what are some of the specific objectives for this Tangendi program? So we aim to capacitate and train women scientists in the acquisition of professional and PhD learning outcomes, to mobilize the training institutions within the network to increase the sensitivity to women's training. Please let us underline that one, sensitivity to women's training. To ensure better recognition of competencies gained through the fellowships. We don't want to train women and not reward them for the skills and knowledge that they've gained. That is one of our other important objectives. So we have 8 PhD female scholars. All of them have been awarded the scholarships and they've registered. I must emphasize that they went through a competitive process. So females competing with females, and we got the 8 that we have. We have 1 from Botswana, 2 from Zambia, 1 from Mozambique, Zimbabwe, Namibia, and Eswatini are some of the countries that are represented within this PhD program. So the fellows are at different universities within the region, 90% of them within African universities, and we have 1 a fellow who's at the University of Barcelona. So you can see the diversity, some are in South Africa, Zambia, Zimbabwe, as well as Namibia. Their areas of research are also diverse, okay? You can see that we have some that are looking at tuberculosis, drugs, COVID-19, antimicrobial resistance, physical therapy and NCDs, Mycobacterium avium complex, vaginal microbiomes, and others are doing experiments on medicinal plants. So we know that as much as they are enrolled in universities, for those of you that have done your PhDs, you know that training programs are diverse in different universities. So we as TESA, we also have our own trainings that we offer, because we have a pool of scientists that could still offer some courses, some basic training to complement what they are getting from their universities. So as you can see in the picture, that is one of the capacity building programs that we hold, and to just make sure that we are moving with them. Our role and aim is that we should graduate all of them when they are supposed to. We work with them. We don't want to end up with 1 student. So we have to make sure that they are all moving at the same pace with our support. So some of the topics that we cover include research methodologies, ethics, data analysis, and also leadership as an important component. This is just to complement what they are doing in their universities, and also when there are trainings that are organized within the consortium, we ensure that we support our students to attend to those that are relevant to them. We have mentorship and support as a key component. So we have experienced researchers with aspiring women scientists. So we have each fellow is allocated to a mentor. Of course, it's similar to what their aspirations are, to offer them guidance, encouragement, and career support. And to sustain this, we also have the fellows, the PhD fellows, mentoring master's students, so that they also practice and take responsibility of those that are coming after them. And to make this to have proper outputs and to ensure that we adhere to this mentorship program, we also have monthly checklists where the mentors and the fellows log in. That way we ensure that this relationship is formalized, and if it's not working, we know what to do. But so far, it's all working, and fellows submit these checklists and the guidelines that we've given to them. So in terms of promoting diversity and inclusion, we have diverse backgrounds in clinical research, and these lead to comprehensive and effective results. And we know that this is going to lead to healthier communities, healthier families, and richer communities. So in our application, we had no age cap. You'll all agree with me in here that at the peak of a woman's career life, that is when her reproductive life also peaks. And many times, we are exposed to, you have to choose. Either you progress with your career, you put your reproductive life on hold, or you do it the other way around. Many times doing both at the same time becomes very difficult. So we didn't want to put an age cap because we know that some women could have delayed their career progression because they wanted to have children, and others are younger. So we also have a provision for maternity leave without taking away any of the benefits. If a fellow falls pregnant while on the program, they'll take maternity leave, they'll have all their benefits. But of course, we have to also look at the regulations for the university where they are registered. We also have an opportunity to provide nursing rooms. You'll all agree with me here again that breastfeeding is key. You know, we don't want the babies to start formula on day one because the mother has to go for work and everything. Provide nursing rooms and provide time for those mothers to breastfeed their babies. Additionally, I talked about travel. Some fellows have to travel across, different countries or even in country. But then many times it's expensive for them. How do they move with the baby and move with someone who's going to mind their baby? So we have a provision also within our grant that if a breastfeeding fellow has to travel for a meeting or for a course, we will also support their minder and also support the baby and give them logistics that they need. You should clap for me for that. So as we conclude, beyond gender equality, empowering women to conduct clinical research is essential for expanding medical knowledge and enhancing healthcare outcomes in Africa. We are actively advocating for policy changes and support initiatives that promote equal opportunities for women in research. On this one, just to reemphasize that most of the consortia sites are in good standing with their governments. So these policies, we don't want them to end at just a Tangendi project and just these 8 women to benefit. It should go beyond. This is just like a pilot. Therefore, by addressing gender and diversity gaps in research leadership, we can bridge knowledge disparities and practically break barriers and build a more inclusive and resilient healthcare system for the continent. I would like to acknowledge EDCTP, universities where the fellows are placed, and also their mentors and supervisors. I thank you all.
Thank you, Mevansa. While the room is getting ready for questions, I was wondering, because you showed very nicely how you support PhD students, but I often have the impression that once a PhD student is finished, and then there's still a huge barrier for female scientists to progress to senior scientist or PI. Is there any support system in place for students that have progressed past the stage already?
So our fellows have not yet, thank you for that question. Our fellows have not yet progressed. The highest is now in year 2. Yeah, but we have a plan that is running in that aspect. I can give myself as an example. I'm now serving as a site co-PI. I joined my PI. I don't know if it's Dr. Duncan Chanda. He should be here somewhere. I joined as a fellow and have been supported through the network. I'm now at the level of a co-PI. So we have a system laid out for that. Thank you.
Thank you. Are there any questions from the audience? I see Hamu.
Yeah, thank you. And I feel I can say I should provide my sincere appreciation to Tessa, especially with the issue related to infrastructure support to breastfeeding fellows or women of child. I mean, those who have those kind of other other choirs to take care of. So I think, as we have said earlier, that you are interested also in changing the policy so that these universities or the develop infrastructures to support female researchers. Maybe I should also provide my comment that if possible, it is high time now to make sure that you work with those ministers, especially related to gender and social development in those countries, so that they not only focus on the fellows, but they include this as part for all. We can start with those universities or research institutions where they will provide this kind of support so that at least to provide a level ground at some extent. Thank you very much.
Thank you very much for those additions.
Are there any further questions from the audience? I think I saw a hand in the back. If there's still a question, please come to one of the microphones.
Yeah, thanks a lot. That was a very good presentation and a very good, plan to help women in science. But I realized you didn't mention about their husbands, so I was just wondering if there's a role. You talk about caregivers, babies, but you omitted the husbands. If the caregiver is the husband himself, is that an option? I just wanted to know if that option exists.
Sorry, I didn't get the last part, I'm sorry.
Yeah, you talked about supporting the babies, and if they have like a caregiver or something to assist the pregnant women or the breastfeeding women, during their courses. If that person is the husband that's going to travel to support the wife, so to speak, I just wanted to hear if there's any option for the husbands of such women.
Thank you very much. That's so brilliant. As we progress as women, we don't want to leave the men behind because we know that we need their support. Yeah, so deliberately, we have a picture there of a husband. So anyone who can mind their baby while they travel is eligible. So husbands are covered. Thank you.
Thank you, Mavanta. I think with this, we progress to the last speaker. Thank you.
So thank you very much for that presentation. So we'll move on to the last presentation of the session. This will be on the role of pathogen genomics in public health, lessons from HIV and COVID-19 towards pandemic preparedness. This will be presented by Dr. Skulile Moyo from the Botswana Harvard AIDS Institute Partnership.
Thank you, Michelle. I'm the last speaker, so standing between you and your break. Thank you to the organizers for the opportunity to present some thoughts around the role of pathogen genomics for pandemic preparedness and some of the work that we have learned and hopefully draw some lessons from these two pathogens and some of the work that in the context of what we've done in Botswana. I'm grateful for the TESA network for the support that allows us to mentor students, and some of the platforms that we have created as an institution have become a resource in the trials, at least for them not to start from scratch, and hence it's important to have these cohorts running. This is Botswana. For some of you who know Botswana, it's known for its diamonds and very rich tourism. So you're welcome to visit Botswana, and when you are there, pass through our institution. That has a history of capacity building for almost 27 years. And our capacity building is at the heart of this institution, and our previous name, we're called the Botswana Harvard AIDS Institute Partnership for research, training, and capacity building. We are now called the Botswana Harvard Health Partnership, and you can see our evolution there from running clinical trials. But the talk this morning is just to appetize you that the last 2-3 years has really taught us the importance of pathogen genomics, not only for individual health, for diagnostics, for monitoring patients, but in the context of public health, from defining the causative agents rapidly. Genomics played a very crucial role in the era of COVID-19, just to know what pathogen we are dealing with, to the first diagnostic tests that were developed after those sequences were released, and also how much the monitoring of movements and activity and variants became very important to know what is going on, what is intensity, the levels of infection to expect. And that was very important as well to development of vaccines and tracking viral evolution, and to investigate introductions and exports of these viruses has become very, very important. And to this audience, is very important, capacity building, creating that ecosystem and an environment to allow these things to happen, not only from good sampling, good samples, to workforce development. We heard from the previous speakers, data systems, and also lately, the analytical skills, including bioinformatics capacity. That is becoming very important in Africa, especially to make sure that we generate the data, but we also have the capacity to analyze the complex data, the big data, to handle it and to store it. It's becoming very important. And also it's important to think about innovative ways of making sure that this data doesn't just end in the lab, but how do we link public health action? So we say data for public health action, and how do we make sure that the reporting and the systems for making data relevant is important, because then it will enhance investment in these systems back if we show critical value for public health. And so we talk about precision public health, which is very important, a novel approach that we can use big data in this era of AI and machine learning to improve population health and reduce health disparities that we were talking about this morning. So we need right interventions to the right people at the right time. And just to highlight some work that has been going on through the Africa CDC, the Africa Pathogen Initiative, which I collaborate very closely, in terms of harnessing the power of collaboration in a very unprecedented way during COVID-19, where at the time there were very few sites that could do some of the pathogen genomics work, and the networks of labs were established to leverage while strengthening, expanding to other sites, and democratizing and allowing this to work. Challenges that were there, shipping samples across even regionals was challenging, but you know that there was so much work that needed to be done. while countries were developing their own capacity. So much work. You heard this quote being said many times during this conference, that if you want to go fast, you go alone, but if you want to go far, you go together. So with more than 400 African scientists, we collaborated, and these are some of the results from really implementing pathogen genomics that really informed public health response and contributed massively in Africa. And some of these capacities are now being used for other multiple pathogens to leverage and pivot from what was established. So you know this story. I hope you know this story. In the beginning of 2019, there were like 7 or so labs that could produce next generation sequencing capability in public health. And by 2022, there were over 31. And that generated almost over 130,000 sequences of SARS-CoV-2. Of course, very little compared to the number of cases that were experienced, almost 1.1%, but globally contributing 2.1%. So it's still very little, but a long way has been achieved in the past few years. Some of the results that you see, increasing local sequencing versus sequencing outside Africa, that has also been beautiful to see. So we talk about how do you leverage beyond COVID-19 to take advantage of this investment. Of course, different use cases, strengthening metadata standards, specimen collection standards, and also making sure that you increase bioinformatics capacity, and also guidelines for data sharing, data analysis, benefit sharing, ethical and legal frameworks around data and how data is used is becoming very, very important. And most importantly, how do you make sure that we are not just generating sequences, but we are really informing public health action? So that's my call. I'm going to use 2 examples from Botswana. One from HIV, which we have implemented for a number of years, using the platform of one of the big trials, the combination prevention trials, so-called the test and treat trials, that really tried to implement a combination of interventions that had been known to work, but put to scale at a population level, they led to massive reductions in HIV incidence. In our case, up to 31% reduction in incidence. But you can see that in some of the trials, there were challenges. And some of the challenges, there was variable success, and between intervention arms of the trial and the control arms. And some of the work that I'm going to show, the role of pathogen genomics in a public health sense, was to tease out some of these effects. What could have diluted the effects? The models show that the intervention effects were even 2 to 3 times more, but could be demonstrated because of the movement of people between intervention and control arms of these trials. So where do pathogen genomics come in terms of inferring direction of HIV transmission in observed clusters, or identifying sub-epidemics, or making sure that we can estimate transition flows between communities was very important. This is where we used pathogen genomics. So we tried to examine the lineages across the different regions in Botswana. Our study was countrywide in 30 villages, as you can see there in the north, the east, and the south. And we used this to sequence deeply whole genomes that allowed us at least to be able to estimate transmission networks and also to infer at some level directionality of transmission. And we did that because we know that identifying clusters by looking at how closely the sequences are from each other, how closely looking at what we call genetic distances, they allow us at least to infer that individuals are in a transmission network or a transmission cluster. This is because in 052, we saw that individuals with pairwise genetic distances less than 5% were in couples or where there was epidemiological linkage of transmission, really underlying that some thresholds can be used to infer these clusters. So what did we find? Using these approaches, we found that most of the clusters were small. So the small clusters, sub-epidemics. In contrast, what you see in Europe, you find very large clusters. You find clusters of 30, 40, up to 100 people. But in our epidemic context, we realize that we find small clusters. Some could have been genotyping density, but we really find low clusters. And this result was repeated as well in Zambia in the POP-ART trial. They also found very, very few clusters. So we are confident that this is a strong result. So we managed to map these clusters. We identified a number of clusters that we identified using these phylogenetic methods. We mapped these clusters, and I'm going to pick one of them, cluster number 8, just to illustrate that there was so much mobility. So in terms of isolating intervention effect, if you don't take care of use of these phylogenetics, you may find that the intervention effect is diluted. In other words, you have infections that are coming from control communities. So cluster 8 is an example where you have 1 male and 7 females in one of the villages, and you can see that these were strongly directed pairs of transmission across the entire country. There were no seroconverters in this cluster, but you can see that this cluster we could identify of individuals that really have similar genetic distances of the virus, showing that mobility is really a factor when you are thinking of these interventions. And so in terms of trying to identify, we no longer use the term hotspots, but if you are trying to look at areas that are really need intervention, so it means that you really need to think differently than the traditional identification of hotspots. It's no longer hotspots. You can see that it's generalized. So you need interventions that think beyond identifying hotspots. So these are the clusters and transmission networks that we identified. Green is good, undetectable viral load in these clusters because we use proviral sequencing to map these. Red, it means individuals who had more than 4 logs of viral load, and that was like less than 10% of those, which is good, meaning that at least in terms of transmission, you still have individuals with detectable viral load, but you can see that they are a smaller part of the pie. And we can characterize these transmissions and see the membership of these clusters, and we are able to at least to provide an additional layer to epidemiological data, or who are these individuals who have these high viral loads. And also we could tell that there were infections, for example, on the right, you see that this is an individual with a new infection, but only clustering with infections from South Africa, meaning that the intervention there could not prevent this infection, but on the left, the infection individuals within the same community. So in that way, the intervention there could be useful to prevent infection because that's a local transmission. And this is what we see in terms of cluster sizes across all our other cohorts as compared to what we see in the UK and in different places. So cluster busting, as we know it in the US, may not work in this context. So it means that scaling up interventions at population level at scale may be more useful than looking for pockets of infection. That's challenging with new infections going down. How do we identify these individuals? So people call it, one of my colleagues calls it, it's an epidemic of many infecting a few as compared to an epidemic of a few infecting many in terms of large clusters. So it really changes the way we think about intervention at a population level. I hope I have time to give you a test of what we did with COVID as well. But we see with HIV that applying pathogen genomics allowed us to confirm the high mobility across the countries, across the country. And also we see that very few clusters with very few people. And fortunately, most of the clusters are virally suppressed. We can look at those sub-epidemics of individuals with very high viral load, try and characterize them, and we see that some of the lineages were localized in 1 or 2 communities, and also we observed a number of transmissions that were really originating from 25 to 34 age groups, which is very important as well. Just quick lessons from SARS-CoV-2. I don't know how much time I have. 2 minutes? Okay. From SARS-CoV-2. Using these infrastructure that we use for HIV, we quickly adapted a nationwide sample referral network that we divided the country into 9 COVID-19 zones that allowed us to move specimens within a very short space of time. And that was very crucial in the real-time sequencing of these viruses and be able to identify variants with speed because of the existing infrastructure. So intentionally including genomic surveillance as part of the national response was important for us at a public health level. Initially, we knew that the virus is evolving. We knew it from HIV. We are always looking at what changes the viruses have. And that allowed us to have a wide genomic coverage for the entire country with a very short turnaround time. From the paper that we wrote with our colleagues from several labs, our country had the lowest turnaround time from collection to submission of sequences. And our target was really making sure that you generate this data within 7 to 14 days. And of course, November 2021 was very unique. Because we are used to looking at these mutations, we have these individuals with an unusual lineage, and which is important from a pathogen genomics perspective, that we characterize these individuals, and it happened to be the first 4 cases of Omicron. And this was very important, not only turnaround time, speed, but also with the ability of trained over many years of analyzing these viruses. You could tell from a phylogenetic clustering perspective, they are clustering away from all other viruses that you see here, but also it allows you now to look deeply in them, and then you realize that they have such horrific mutations that you have not seen. Of course, it made us delay a little bit by going back to the lab, but at least when we confirmed that these are real mutations, we could release them to the world. And you know the noise that came after that. I won't talk about that. And so it was a collaborative effort with colleagues as well in South Africa, with a few hours apart detecting similar sequences. That was very important. You can read this work. And recently, because of looking at this, we've been able to characterize, unfortunately, this is a fatal case of a recent Omicron subvariant FL2, which showing a rapid accumulation of intra-host mutations within these individuals. On the right, you can see this is where the individual started with, and then you can see that they developed several levels of mutations in host. So we're following this individual over time, and unfortunately, this individual did not make it. This paper has just been accepted in the International Journal of Infectious Diseases. You can read about how we were monitoring the evolution of this patient as he was being treated, and meaning that viral evolution is still important. This is a breakthrough infection, fully vaccinated, fully boosted, but with a nasty viral evolution escape. We also demonstrated in a context of One Health that we can detect SARS-CoV-2 in a dog. And of course, we know that this has had a serious public health implications, and you can see that it changed the way in which the US was responding to their epidemic. We didn't have such resources, although we found this variant. They could quickly arrange and get people boosted, and that's what we should be addressing in the terms of pandemic preparedness. How do we go from detection to response, not just detecting and other people respond? I think we need to change that narrative. Of course, this is that was important that it impacts the world, and now we are beginning to look at pathogen discovery from different sources, from the environment and from vectors, and collaborating with others. So in summary, genomic surveillance can inform public health action at local, international, and regional level. Building on existing infrastructure to pivot and leverage is becoming very, very important. We're looking at multiple pathogens going beyond COVID is becoming important. There are ethical issues rising up, not only around data sharing, but benefit sharing. How do you make sure that where work is done, there's benefit? I would like to acknowledge my institution and the bodies that have supported us, including the WHO and the Africa CDC, the president of Botswana, and the President of South Africa and the institutions I represent here, and also the next generation of scientists that are rising up, building on some of these platforms and some of the students that my colleague was talking about, at least pivoting on this to be able to raise the next generation. And this is the team that we work with. It's a large team, and we appreciate the sacrifice that they all put into bringing science in Africa to the table with very limited resources, and acknowledge the funders and the TESA network, my institution, and everybody who has played a part in the Ministry of Health, who has been very instrumental in creating an environment for us to do our work, the Phylogenetics Network for training and capacity building, and a message of thank you to everyone. Thank you.
Thank you, Dr. Moyo. Any questions from the floor? All right, so I have one question. You mentioned your collaboration with South Africa. What are some of the factors that have enabled successful collaboration with your counterparts in South Africa?
Yeah, collaborations are very important. They are not easy to maintain, but they are very, very important. So traditionally, I was trained partly in South Africa for my PhD at Stellenbosch University. So it was naturally easy to build and leverage on that network. But also we intentionally established a network of genomic surveillance within the region, working with Africa CDC, with the Pathogen Genomic Institute. That included more than 100 labs. We're sharing protocols, we're sharing ideas. We'll meet every week and share those ideas. So I think leadership is important for senior scientists to create that environment of collaboration, allowing individuals to train across institutions. Even our institution was hosting people from almost like 5 countries through our network for TESA for sequencing training. So I think that's important, so that when things like this come, you can easily pick the phone and talk to your colleagues, and it validates your work as well.
Thank you. Any more questions? I guess the silence means that your presentation was clear and...
It's just before lunch.
and people want to go eat.
Thank you.
All right, thank you very much, and congratulations on your award. So with that, I'd like to bring the session to a close. Thank you very much for everyone who participated, who attended, and yes, let's go for lunch. Thank you.